Hello everyone. In continuation with the series of lectures in vasculitis, today we will discuss about medium vessel vasculitis, which is polyarteritis nodosa. So let's begin. So first we will be looking at the key features of polyarteritis nodosa one by one. So polyarteritis nodosa is a medium vessel vasculitis. It involves predominantly the medium vessels, and to a certain extent it can involve the small vessels as well. So what do you mean by medium vessels? Medium vessels means what sort of vessels? It includes the mesenteric vessels, which is your GI vessels, and it can involve your coronaries as well, right? Similarly, testicular vessels. So all these are examples of medium vessels. Okay. So when you speak about polyarteritis nodosa, what is the characteristic histopathological feature which you will find? So you will find evidence of a necrotizing vasculitis. So similar to your ANCA associated vasculitis, which are small vessel, here also you find evidence of a necrotizing vasculitis, and you find evidence of pan-arteritis, right? So all the layers of the vessel wall are involved. Polyarteritis nodosa is a disease of the middle age, 40 to 60 years of age, and both males and females are affected in an equal proportion. The most important association of polyarteritis nodosa that we should be aware of is that it has an association with hepatitis B. Okay, so 30% of the patients of hepatitis B can have polyarteritis nodosa. Okay, so 30% of the patients of hepatitis B can have polyarteritis nodosa. So the most important association is with Hep B. Okay, so polyarteritis nodosa is a disease of the medium vessel. It is a necrotizing vasculitis involving all the layers of the vessel wall. It is common in the age group of 40 to 60 years of age, affects males more than females. So let us look at the clinical features of polyarteritis nodosa one by one. So very importantly, it can present with constitutional symptoms. So the most important constitutional symptoms are fevers, myalgias, arthralgias, weight loss. Okay, so all these constitutional symptoms can be present. So polyarteritis nodosa can be classified as classical pan and cutaneous pan. Okay, classical pan has lot of other clinical features. Cutaneous pan is predominantly limited to the skin. So when you look at the cutaneous involvement, the characteristic rash that we see is what we call as the Livedo reticularis. It is called as the Livedo reticularis. So you can see the evidence of this net-like lacy appearance of this rash, which can be seen in both the hands and feet, which is a characteristic rash of pan. Apart from this, there can be other forms of rashes, which includes maculopapular rashes. Maculopapular rashes can be present. You can have small vessel involvement concomitantly, and you can have a palpable purpura as well. And because of this medium vessel involvement, there is a tendency of vasculitic ulcers, vasculitic chronic non-healing ulcers can be there, and there is an increased risk of gangrenes as well. So the most specific, or if you see the characteristic rash which is described in pan, is a Livedo reticularis rash, but you can find evidence of maculopapular rashes, vasculitic ulcers and gangrenes. So whenever we speak about polyarteritis nodosa, it can involve literally any system, right? So especially the classical pan, it can involve the CNS, it can involve the heart, it can involve the GI, the renals, but one particular system where pan is least common in, least commonly involved organ is the lungs. Okay, so always remember that the pan can involve any organ, and the least commonly involved organ is the lungs. Okay, but so if at all we have a bronchial artery involvement, it can present with hemoptysis. Okay, then renal artery involvement, since it involves the medium vessels, renal artery can be involved. What do you find? You find evidence of microaneurysms. You find small outpouchings within the renal artery. These are what we call as microaneurysms, and this can also result in sometimes a stenosis and result in a renal artery hypertension as well. Okay, so this can result in a renal artery hypertension as well. So hypertension in young, or if there is evidence of a unilateral contracted kidney because of renal artery stenosis, you can think of polyarteritis nodosa. Okay, fine. Then arteries, involvement of the mesenteric arteries, what will it result in? It can result in GI hemorrhage. It can result in GI hemorrhage, lower GI bleed or upper GI bleed. Upper GI bleed can result in melena. It can result in melena, GI hemorrhage, and it can result in bowel angina. Bowel angina because of vasculitis of the arteries that supply the intestine. Bowel angina is characterized by severe abdominal colicky pain, especially which is increased after food. It increases after food. Okay, so there can be GI hemorrhage, there can be bowel angina. Then testicular artery involvement in males can result in severe testicular pain. It can result in severe testicular pain. In females, it can mimic an appendicitis. It can cause ovarian pain as well. Okay, so testicular pain, GI hemorrhages, microaneurysms in the kidney, livedo, reticularis. If at all rarely the bronchial artery is involved, it can result in hemoptysis as. Then peripheral nervous system. In the peripheral nervous system, because of involvement of arteries that supply the nerves, you can have mononeuritis multiplex. Mononeuritis multiplex. Okay, so what is the meaning of mononeuritis multiplex? There is involvement of non-contiguous nerves. So you may have a radial nerve palsy, you may have a separate ulnar nerve palsy, you can have peroneal nerve palsies. All of this because of vasculitis of the arteries that supply the nerves. Okay, so mononeuritis multiplex. Alright, in the CNS, if there is evidence of CNS vasculitis, they can present with strokes. Cardiac involvement, especially if the coronary arteries are involved, there is an increased risk of MIs, there is an increased risk of myocardial infarction, and myocarditis can present in the form of a heart failure like picture with pedal edema, abdominal distension and breathlessness. So you can see here that literally almost any organ can be affected by your polyarteritis nodosa. Okay, so this is nothing but an image showing the multiple microaneurysms which you can see because of your vasculitis, especially in the kidneys. Okay, and always remember the least commonly involved, or you can almost say the organ which is not affected at all by a polyarteritis nodosa is your lungs. Okay, so just to reiterate, the common clinical features are constitutional symptoms, vasculitic ulcers because of medium vessel involvement, gangrenes, livedo reticularis. You can have bronchial artery involvement, can cause hemoptysis, renal artery microaneurysms, mesenteric arteries GI hemorrhage, testicular pain because of testicular artery involvement, ovarian pain, mononeuritis multiplex, myocarditis, right? So this is about the varied clinical features in which polyarteritis nodosa can present. Now, what is the investigation of choice? The investigation of choice for diagnosis of the polyarteritis nodosa will be an MR angiography. So if you do an MR angiography, you find evidence of microaneurysms. Okay, so if there is a patient who is presenting to you with evidence of vasculitic ulcers and GI bleeds, so how will you know if this is polyarteritis nodosa as well? So polyarteritis nodosa is a clinical diagnosis, and if you see the blood markers in the blood, what are the investigations that you will find? You may find evidence of anemia. You may find evidence of anemia, a mildly low hemoglobin. You may find evidence of leukocytosis. Okay, then there can be elevated inflammatory markers, raised ESR and raised CRP can be present. Right? So whenever a patient presents with vasculitic ulcer, you will have to do a workup for whether this is a medium vessel or small vessel, and if you do an ANCA, this will be an ANCA negative vasculitis. It is going to be an ANCA negative vasculitis. Okay? If you take a skin biopsy, will you find evidence of any deposition? Right? If you think of IgA vasculitis, yes, you will find evidence of deposition because it's an immune complex mediated. Here there will be no immune complex deposition. There will be no immune complex deposition, right? So you will only find evidence of vasculitis, and predominantly it will be a medium vessel vasculitis. Fine, right? So ANCAs will be negative here. So this is how you basically diagnose a patient with polyarteritis nodosa. Clear? Okay. So how do you manage a patient with polyarteritis nodosa? Like I told you that hepatitis B is the most common association of polyarteritis nodosa. So if there is a hepatitis B positive patient, then the treatment predominantly involves the use of antivirals. Use of antivirals along with plasma exchange therapy is a cornerstone in the management of patients with PAN in hepatitis B positive patients. So many of them are going to respond to your antivirals. But if it is a hepatitis B negative patient and they have a PAN, then steroids and cyclophosphamide is the treatment of choice. Okay, fine. So this is about your polyarteritis nodosa, which is a medium vessel vasculitis. Thank you.